Hello, my name is Irina Davis, and my presentation is about metoprolol and CYP2D6. Metoprolol is a prescription drug known under a variety of trade names, such as Loprasor in the United States. It is a widely used drug that has been on the market since 1978 when it was first approved by the FDA. Metoprolol is a selective beta-1 receptor blocker. It targets receptors in the heart and kidneys. It interferes with stress hormone binding, creates fight-or-flight response. Overall, it relaxes blood vessels, slows heart rate, and decreases blood pressure. Metoprolol is used alone or in combination with other medications to treat diseases of the cardiovascular system, particularly hypertension. It is also used to prevent angina and to improve survival after a heart attack. Interestingly, it can also be prescribed off-label for such conditions as social anxiety disorder, performance anxiety, irregular heartbeat, prevention of migraines, and movement disorders. As any drug, metoprolol has a long list of potential adverse effects, particularly if taken in higher doses. Some of the adverse effects include dizziness, drowsiness, fatigue, depression. It can also cause reduced blood flow to the hands and feet, and because it has high penetration rate in terms of the blood-brain barrier, it can cause nightmares and sleep disturbances. Here are some facts about metoprolol pharmacokinetics. Important bit here is that it is metabolized hepatically, primarily by CYP2D6. And CYP2D6 is a very important enzyme encoded by the CYP2D6 gene, which is primarily expressed in the liver. It is a key enzyme for drug metabolism and elimination, and it is involved in around 25% of common drugs. It is the only non-inducible enzyme among CYPs and highly polymorphic with over 90 known allelic variants. And these variations in CYP2D6 can be categorized in 4 groups. So patients can be described as either poor, intermediate, extensive, or ultra-rapid metabolizers, depending which alleles they have. Extensive metabolizer type is considered to be normal. And there is some variation across populations and ethnicities. Poor metabolizers are mainly found in Europe, intermediate ones in Asia, and ultra-rapid metabolizers in North Africa and Oceania. There is a significant functional impact of CYP2D6 variations and metoprolol. FDA has pharmacogenetic information on the label for metoprolol, and it states that if a patient is taking metoprolol at the same time as they are taking CYP2D6 inhibitors, they might have increased blood levels of metoprolol, which would decrease metoprolol's cardioselectivity. There is also a Dutch pharmacogenetics working group guideline that goes further and actually provides detailed information on dosing of metoprolol depending on which metabolizer group a patient belongs to. When I've done the critical review of the evidence behind metoprolol and CYP2D6, I've encountered some challenges because, of course, we don't have the CPEC guidelines for it, but we do have the Dutch guideline, as I've mentioned, and it states that it's based on good quality evidence. At the same time, GKB clinical annotations of low quality for CYP2D6 SNPs and metoprolol. Although there is a little bit of controversy evidence, I do think that metoprolol and CYP2D6 drug gene pair is ready for implementation in a clinical setting. First of all, we know a lot about CYP polymorphisms overall. Second, we can use the Dutch guideline as it is implementable. And I'm also working on a University of British Columbia pharmacogenomics project, which is aimed to design a clinical decision support system for care, and it will include metoprolol as one of its drugs. My primary sources were PharmGKB and Medline Plus, and the overall conclusion is that this drug gene pair is implementable in a clinical setting. However, further scientific inquiry is warranted to boost the evidence levels up. Thank you very much.